Part 2 of thrombosis and thrombophilia. Deep vein thrombosis. About half of the people with deep venous thrombosis, you will find no symptoms in them. It means silent deep vein thrombosis. In this picture also we see patients with unilateral swelling of the lower limbs, discoloration, and in the picture on the left side you can find the veins congested. This is a superficial vein. Sometimes superficial phlebitis or thrombophlebitis associating deep vein thrombosis. What is the differential diagnosis? If we find a patient like the previous one, what we are going to think about him? We may think about cellulitis infection, as you see in the in this picture. This is a cellulitis and not a DVT. Why? Because there is line of demarcation and evidence of inflammation is present. Another differential diagnosis is muscle tear or strain, lymphangitis and lymph obstruction. It means inflammation of the lymphatic vessels, venous valvular insufficiency, or rupture popliteal cyst. Arterial occlusion, but arterial occlusion, the skin will be cold and not hot, and the color changes. You can find ischemia, signs of ischemia, and pallor or even dark color of the skin. How we are going to investigate patient with DVT? First, by doing after clinical suspicion, after clinical examination, we can do D-dimer test. D-dimer is a byproduct of the coagulation cascade. D-dimer test only useful to rule out DVT if it is negative. So if it is negative, it may be no DVT. With low clinical suspicion of disease and no other acute medical issues. And if you are still suspecting on clinical ground the DVT, if it is negative, don't rely on it. Try to repeat it again. Easy and bedside tests, we can do it. Doppler ultrasound. Doppler ultrasound is most useful diagnostic test for DVT. Sensitivity and specificity for proximal DVT about 95%, and for DVT in the cuff maybe less, around 70%. Other non-invasive tests include MRI and impedance plethysmography. Venography is the gold standard, injecting vein inside the suspected vein thrombus and take an X-ray picture. Venography is the gold standard, but it is expensive and invasive and with high risk of injecting dye, may make anaphylaxis. This is angio. In the middle you can see the dye inside the blood vessels, and you can see here the thrombus obstructing the flow of the vein. On the left side, this is the Doppler, and you can see also here the thrombus inside the blood vessel, and here the MRI showing thrombus inside the inferior vena cava. Thrombophilia workup. When we find patient suspecting that he has a thrombophilia or tendency to thrombosis or unexpected thrombosis, you have to do for him thrombophilia workup. Initially, CBC, blood smear, coagulation study, liver and renal function, urine analysis, fasting homocysteine level, antiphospholipid antibodies in the form of anticardiolipin antibodies, IgG and IgM, lupus anticoagulant, activated protein C resistance, DNA molecular study for factor V Leiden, prothrombin G2210A or JAK2. JAK2 is a JAK mutation. Usually we find it in myeloproliferative disorder, and it is one of the most important diagnoses now for patients with myeloproliferative disorder. Also, we can test for a disease called paroxysmal nocturnal hemoglobinuria by flow cytometry and doing CD 55 and 59. Post initial insult, it means if more than 72 hours after thrombosis, we can do antithrombin, provided that the patient not on heparin, and we can do factor 8 concentration. It may be increased, and if it increased, it predicts recurrence. Post treatment, after stopping warfarin or oral anticoagulants, we may test at that time for protein C and protein S. Take care that most of these tests don't change management, and a negative test does not rule out a hypercoagulable state. Thus, more focus is on the reversible or treatable causes, like antiphospholipid antibodies or lupus anticoagulants, to find the cancer and to treat it. It means that في معظم الأحيان we treat the patients regardless of the results of these tests for thrombophilia. And so why we are doing it? We are doing it for follow-up and to know if the patient is going to recur or to relapse as regard thrombosis or not. But the treatment will not differ according to or will not differ or depend on the results of this thrombophilia, but the difference will be in the prognosis and expecting more thrombosis later on in life. How we can treat patient with venous thromboembolism? First, why we have to treat? We have to treat to prevent extension of the blood clot. So we usually give the treatment, anticoagulant treatment, for 3 months in the first attack. Second, to prevent acute pulmonary embolism. If we leave the patient with DVT, he may die from pulmonary embolism. It is a sequelae of DVT, detachment of the thrombus and go and lodge it inside the blood vessels of the lung and causing a serious life-threatening condition called pulmonary embolism. Usually pulmonary embolism occur in up to 50% of untreated patients. Also, we treat to reduce the risk of recurrence, to prevent recurrence. And this will depend on the presence of risk factors. To prevent lower limb ischemia in extensive thrombosis or dangerous thrombosis, يبقى treatment of massive iliofemoral thrombosis with acute lower limb ischemia and or venous gangrene. And to limit development of late complication, post-phlebitic syndrome, chronic venous insufficiency, and chronic thromboembolic pulmonary hypertension. So for all these reasons, we have to treat and take decision to treat the patients. Sometimes there is contraindication to treat the patient. Unfortunately, some patients may have a contraindication for treatment, like those with active bleeding, peptic ulcer, intracranial hemorrhage, something like that. Severe bleeding diastasis or platelets less than 20. We cannot anticoagulate further anticoagulate the patient. Otherwise, it will cause for him bleeding, and it will be dangerous to give him anticoagulation. If patient has intracranial bleeding, active intracranial bleeding, if patient is going to neurosurgery or ocular surgery or did it within last 10 days. Relative contraindication. Relative means it is according to the condition. We can take the risk of anticoagulation if the benefit will weigh the side effects. When it is relatively contraindicated to anticoagulate the patient, in case of mild or moderate bleeding diastasis or mild thrombocytopenia, if there is brain metastasis or recent stroke, recent major trauma, major abdominal surgery within the last 2 days, gastrointestinal bleeding within 1 to 4 days, or ulcerative disease, endocarditis. Here we are afraid from shedding of the infected thrombus if we give anticoagulation, and it will make a septic emboli all over the body. Severe hypertension, if the blood pressure above 200, control hypertension first and then anticoagulate the patient. Or the diastolic is above 120. So systolic above 200 or diastolic above 120 is a relative contraindication for anticoagulation. You have to treat the patient first and then give anticoagulation. What is the treatment? Heparin. Heparin, either low molecular weight heparin, it is given subcutaneously. Advantage of low molecular weight heparin: predictable dose response and fixed dosing schedule. Lab monitoring not required. Yani we don't need to do follow-up or monitoring laboratory tests. The incidence of heparin-induced thrombocytopenia is low, up to less than 1%. It is a safe drug and effective, especially in outpatient therapy, as an outpatient therapy. What is the disadvantage? The disadvantage only partially reversible by protamine. Yani if the patient is over anticoagulated, there is no antidote. The protamine make a partial reversible effect of low molecular weight heparin. Also, it is if long-term use may lead to osteoporosis. In patient of renal dysfunction, also it is dangerous because it needs renal clearance, and overdose because it is not cleared well. So in case of patient with renal dysfunction, low molecular weight heparin is not recommended. We usually use the unfractionated heparin because it has a shorter duration of action, half-life is less, and it can be reversed easily by protamine. So unfractionated heparin used in patient with average risk of bleeding. Advantages: rapidly reversible by protamine. Yani if I give overdose or the patient over anticoagulate, I can reverse it by a medication, another medication called protamine. A disadvantage: it need monitoring. I need to do the ABTT test, activated partial thromboplastin test, with adjustment of dose to reach a therapeutic level target. But this is in contrast to the low molecular weight. We don't need to do these tests for follow-up, because in case of unfractionated heparin we have a target. Our target is to double the activated partial thromboplastin time. In case of low molecular weight heparin, there is no target. We use it according to the body weight, and it is a fixed dose according to body weight. One of the disadvantages of unfractionated heparin also is the HIT, or heparin-induced thrombocytopenia, and so we have to monitor by CBC frequently. Alternative to low molecular weight heparin and unfractionated heparin is the heparinoids, especially this is used in case of heparin-induced thrombocytopenia to bypass the effect of heparin with the platelet. Direct thrombin inhibitor like herwidine, libriodine, argatroban, and dabigatran, and factor 10 inhibitors like fondaparinux and rivaroxaban. Thrombolytic drugs. Sometimes we may need to use thrombolytic drugs. The previous drugs we mentioned, heparin and its substitutes, is anticoagulant. These drugs like streptokinase and tissue plasminogen activator is a thrombolytic drug. It acts on the thrombus to dissolve it. This line of treatment need to be inside the ICU, and it is reserved for acute threatening or life-threatening thrombosis and low bleeding risk. After initial treatment with anticoagulation with heparin, the patient needs to be maintained on anticoagulation for a time. What we are going to do, we are going to give warfarin, standard treatment, and should be initiated with heparin, or must be an overlap between heparin and warfarin. So we usually start warfarin all together with the starting of heparin. Why? Due to initial prothrombotic states and the half-life of the vitamin K factors, we have to guarantee that the factors has been depleted, and risk of warfarin-induced skin necrosis. This overlap lasts for around 5 days. Discontinue heparin after the INR reached 2, doubled for 2 consecutive days. Warfarin should be dosed to maintain the INR from 2 to 3, except in selected cases. You have to monitor INR twice weekly for 1 to 2 weeks, and then weekly until INR become stable, and then every 2 to 4 weeks according to the case. For how long we are going to give anticoagulation? First episode, anticoagulate the patient for 3 months. First episode with ongoing risk factor. What is risk? Like what? Like cancer, like patients with antiphospholipid antibody. All these are risk factors for recurrence. So, if there is more than one risk factor, consider indefinite therapy. First episode of DVT with no identifiable risk factor or single inherited risk factor, for example, in case of factor 5 laden, 6 to 12 months or indefinite therapy. This is according. So if patient with found to have factor 5 laden, resistance to activated protein C, and has DVT now, you have to anticoagulate him from 6 to 12 months. In some centers, they give him indefinite, long life anticoagulation even after the first episode. If recurrent DVT occur, so we have to decide to give indefinite anticoagulation therapy. Inferior vena cava filters. Sometimes we put these filters in cases with contraindication to anticoagulation. This green field filter inserted into the inferior vena cava to catch the blood vessels in order to prevent or to protect against pulmonary embolism. So temporary filter indicated only if distal acute DVT with significant contraindication to anticoagulant therapy. For example, during active bleeding. Must remove once safe to do so, as the filter is prothrombotic. It is a foreign body, so the filter itself may induce thrombosis. Once we stabilize the patient and start anticoagulation, we have to remove it. Prophylaxis against deep venous thrombosis. Prophylaxis considered for those with a moderate to high risk of thrombosis without contraindication for anticoagulation. Non-pharmacological measures include early ambulation or elastic compression stocking, like that in the picture in front of you, intermittent pneumatic compression. We may give unfractionated heparin or low molecular heparin according to the protocol of the treating center as a prophylaxis against thrombosis in selected cases. Post-thrombotic syndrome. After thrombosis and deep venous thrombosis, there is a complication. Usually the vascularization in the blood vessels is not good, and so you may find this picture. Darkening of the skin, skin ulceration, persistent pain or heaviness in the lower limb, nails may be brittle or changed color of nails. The overall frequency of post-thrombotic syndrome after symptomatic DVT ranged from 20 to 50%, with severe post-thrombotic syndrome occurring in 5 to 10% of patients with DVT, skin pigmentation and ulceration. Pulmonary embolism. What is it? It means lodging of a blood clot in the pulmonary arterial tree with subsequent increase in pulmonary vascular resistance. I mean pulmonary hypertension, impaired ventilation perfusion, and reduce pulmonary blood flow in severe cases. What is the etiology and pathophysiology of pulmonary embolism? It is one of the most common cause of preventable deaths in the hospital. Proximal leg thrombi, I mean popliteal or femoral or iliac vein thrombosis, are the source of most clinically recognized pulmonary emboli. Thrombi often start in cuff but must propagate into proximal vein to create a sufficiently large thrombus for a clinically significant pulmonary embolism. Less than 30% of patients have clinical evidence of DVT. Less than 30% of patients have clinical evidence of DVT. It means that if you find pulmonary embolism, try to find underlying DVT. Even if it is not clinically evident. Try by heart to find DVT, to check for leg swelling, for pain, tenderness, or to do investigation. Usually there is something underlying. Always suspect pulmonary embolism if patient develop fever, sudden dyspnea, chest pain, or collapse 1 or 2 weeks after surgery. Sometimes it is the second day of surgery. Pulmonary embolism may happen on table. So pulmonary embolism must be treated on suspicion. I mean, treat the patient as pulmonary embolism until proved otherwise. Suspect pulmonary embolism in every patient with sudden unexplained dyspnea and tachypnea. Dyspnea and tachypnea and tachycardia means pulmonary in predisposed patient, sure. Unexplained dyspnea and tachycardia means pulmonary embolism until proved otherwise. Treat the patient is better than leaving him to die. It is a fatal condition, and at the same time it is a preventable condition. What is the investigation if we are suspecting pulmonary embolism? Start by doing rapid ECG, but it is not conclusive and don't depend on it. Chest X-ray, not useful, but may give us the underlying condition, or in massive pulmonary embolism it may give opacities. D-dimer also is very important. If negative, in low risk patient, if negative, you can rule out pulmonary embolism. Ultrasound or Doppler has high sensitivity and specificity for proximal clot, but only 73% sensitivity for DVT below the knee. So you have to repeat it if you are still suspecting a DVT. CT angiography or spiral CT has high sensitivity and specificity for pulmonary embolism. It is easy and it is not costly, and we can do it to exclude if you are suspecting DVT. It is a very important investigation. CT angiography. Ventilation perfusion scan is useful when the CT angiography is not available. Before we used to do this scan, it is difficult and expensive, but now we are doing CT angiography. How we are going to manage? Anticoagulation. Anticoagulate the patient either by low molecular weight heparins or oral anticoagulant, or the new oral anticoagulant rivaroxaban, the Relto, can be used in both acute management of symptomatic DVT or pulmonary embolism and extended treatment. We usually use 15 milligram for rivaroxaban twice daily for 21 days, and then prophylaxis by 20 milligram orally daily for all the period of prophylaxis as the schedule before discussed. Inserting inferior vena cava filter may protect the patient from pulmonary embolism in those contraindicated for anticoagulation. Thrombolysis if it is extensive DVT or pulmonary embolism, or if there is a hemodynamic compromise. Often we can treat patient with DVT as an outpatient now in the presence of the oral anticoagulant. Admission of patients with DVT if we are suspecting pulmonary embolism, or if the patient is hemodynamically unstable, need oxygen, or if there is major comorbidities, or if the patient unable to ambulate, or if he needs invasive therapy. Long-term anticoagulation, if reversible risk factor, we will give 3 to 6 months of warfarin therapy or any other oral anticoagulation. In case of idiopathic vena thromboembolism, we may need longer duration of anticoagulation, up to 5 years and sometimes indefinitely. Thank you.